Cardiograms are done here by our doctor, Dr. Bala. And when we talk of reduced ejections of fractions, it is the strength or the ability of the heart, that ability of the strength that the heart uses. Basically, anything less than 25% is called severe heart failure, because the heart needs strength to pump blood. From 26 to 40, we call it a moderate heart failure. That is the degree of severity. Moderate heart failure. I'm talking about the ejection fraction, because we meet it here as a reduced ejection fractions within the systolic heart failure of the left ventricle. And then anything from 41 or 45 to 50, basically, or 40 to 45, it depends with the calendar that you use. We have the American calendar and the rest. It gives you a mind. Nowadays, we don't say heart failure with reduced ejections of fraction with the knowledge that I have as per now. We came to heart failure with mid-range ejections of fractions, but anything from 40 to 45, we term it as heart failure with mildly reduced ejections of fractions. Then we also have the diastolic heart failure, where we call as preserved ejection fraction. You have to understand one thing with the echo. Any ejections of fractions that are from 50 and above, basically from 50 to 75, that is our landmark. It is heart failure with preserved ejections fractions. We have ejections fractions that supersede 75. We call it 76, 77, it can go up to 90 or 80. We call it heart failure with supranormal ejections of fraction. But we basically focus on preserved ejections of fractions, and we also focus on reduced ejections of fractions. I'll take you through a baseline evaluation of the structure of how we talk about the echo. What Daktari does basically, he checks the structure of the heart. He checks using the echo probes, and then the echo machine helps us to understand the functionality of this heart. We use both the parasternal long axis and the parasternal short axes to access the heart in different views. And then when we come there, we must check the structure of the RA. The RA must not exceed 4.0 centimeters per se. We talk of the RB, it should not exceed 3.0 centimeters when you're talking about the structure of the heart, because it is really taking us there through the definition of both the systolic and the diastolic of reduced ejections of fractions and preserves of ejections of fractions. Then we talk of the LA, it should not exceed 4.0, and we also talk of the LV, that should not exceed, the LV should not also exceed at 4.0, and also it should not exceed, we have the systolic and the diastolic. We have 4.3 and 5.6. So those are the things we tend to see. Then we come at the chambers. These chambers, if they all become dilated, we call that dilated cardiomyopathy, and that is also a kind of the heart failure. When we talk now of the ejections of fractions, that ability is determined by the LV. We use two methods in that. We can use the LV take method, or we can use the Simpson's pipelines method to evaluate the strength of the ability of the ejections of fractions of these muscles of ours here that tends to pump blood and release it to the rest of the parts of the body. And that is how we come to the definition of reduced ejections of fractions and preserved ejections of fractions. Also, we will look at the up and down movement of the heart. When we are looking at the up and down movement of the tricuspid region, we are talking about the tricuspid, annular, pulmonary what? Plain excursion, yes. And then on the mitral region, the TAPSE should not exceed 1.8, if I'm right, Daktari. Because anything that is below 1.8, impairment begins from there. From anything less than 0 is severe, up and down movement. Longitudinal function becomes impaired. Anything from 2.1 to 2.3 is moderate. From 2.3 to 1.8, or no, 1.3 to 1.8, it becomes mild. So we want it to be as from 1.8 and above. We call it normal longitudinal function. Yani, the up and down movement of this region. We use the continuity wave to analyze. Then we come to the mitral region, whereby we have something so called as MAPSE. That is the mitral, annular, pulmonary calcification. So it's the up and down movement of the mitral region. So it has to be checked through the echo. We also check the IVC. Does it collapse? When the patient tends to sniff,